Hello, and welcome everyone to our webinar today, IAHSS Security Design Guidelines, What's New in the Third Edition Update. Thank you all for taking some time out of your day to join us. I think we have a great session planned for today. My name is Dan Kuzneski, and I'm Director of Marketing with MetroSense and the host for today's discussion. For those that might be less familiar with MetroSense, we're the leading provider of advanced magnetic detection technology. Our ProScreen 200 detection systems are protecting hospital emergency departments, psychiatric hospitals, and behavioral health centers around the world. Before we continue, I'd like to go through a few housekeeping items. On your screen, there are several items that make up our council today. In the upper left is the media player. And at a point later in the presentation, there will be a video played, and it will show in this media player. Below that is a Q&A window. You can submit questions at any time throughout today's webinar, and we will do our best to answer as many of them as possible. Simply type in your question and hit the submit button. In the center of the screen is your slide console. This is where the slides will display throughout today's presentation. If you would like to make this area bigger or any other window area bigger, use the controls at the top right of the console window. In the upper right is a resources list. You'll see that there is a link to purchase the IAHSS Security Design Guidelines, Third Edition Update, as well as some additional resources from MetroSense. In the bottom right is the biography for today's speaker, Tom Smith. And at the very bottom are icons that control all of the windows. If you click an icon, it will make a window disappear, and if you click it again, it will bring it back to your console. So with that, let's get started with today's webinar. And let me introduce Tom Smith, today's speaker. Tom is President and Principal Consultant for Healthcare Security Consultants, Inc. He is a healthcare security industry veteran that's been in the industry since 1981 in a variety of roles with community hospitals, inner-city medical centers, and university-based healthcare systems. He is the past president of the International Association for Healthcare Security and Safety. He chairs the IAHSS task force in creating the security design guidelines for healthcare facilities. He's a member of the IAHSS Guidelines Council, as is Healthcare Security Council and the American Society for Healthcare Security Engineering, ASHE. He's a frequent guest speaker on healthcare security-related topics. So without further ado, let me introduce Tom and turn the presentation over to him.
Thanks, Dan. As you said, I'm glad you didn't say I was old, just since being in the industry since '81. But I'm sure a lot of our listeners were born around that time. But I started off working at a small community hospital in Saginaw, Michigan. Worked there 3 years. Worked at a larger inner city medical center in Flint, and worked there for 9 years, and then moved to University of North Carolina Healthcare System. In '92, worked there for 22 years as Director of Hospital Police Parking and Transportation. And during that time was working with the Healthcare Security Consultants, and left UNC in 2014 and been doing the consulting thing for full time now. I guess what that gave me, the perspective of working in those variety of locations, having been in hundreds of hospitals over the last few years. One of my big takeaways was with all the design, renovation, and construction, my experiences in design were very frustrating, and we'll talk a little bit about that. And sort of the impetus for these design guidelines came out of that, the experiences that we had there. And a lot of you that may have seen me before, I always have something like this in here that good judgment comes from experience, and a lot of that comes from bad judgment. If you think about the things that you learn the most from was where maybe you made a mistake, maybe you didn't show the best judgment, but you'll learn from those things, and those that you survive from, that helps you with the judgment later on in your career, and that's certainly been accurate for me. Couldn't help throw in something about COVID, the relative importance in 2020 so far. I saw this, Accidental Life had this thing, and it just really, for me, it hit a humorous spot, and I got to throw some in here. Live presentations we can throw in a little bit more, but when you think about, the relative importance of sweatpants was pretty low in January, but oh my goodness, now it's pretty high. But shaving, not so important. The internet was already kind of important, but it's much more important nowadays. Coffee, of course, is high up there, and I had to add my own little addition there as beer seems to be more and more important to me as we move through this COVID experience. But sorry about that. I had to throw that in. We're gonna kind of really cruise through these slides. There's a lot here. This is an introduction to the design guidelines that have been developed. And we want to talk about, an overview and talk about what's most important, I think, and some of the bigger changes. But you're going to get just a skimming the surface, so I encourage everybody to go to that website, buy those guidelines. The member price is extremely low. The print is $75, the ebook's $49, non-members $125 and $99. It's just a heck of a resource to have in your bookshelf and something that I'm sure you'll use frequently with all the construction and new construction that's going on in the healthcare industry these days. We're going to talk about what's important and why is security increasingly important. We're going to talk about the new elements in the design guidelines, the areas covering long-term care. More extensive updates were done in the emergency department and behavioral health units. And there's some additional material for clinics, and all the references, all the guidelines were updated. But those are the ones that were most heavily impacted during this new edition. And we want to provide you with a background and design elements to include in every project, because I really do believe security, those of you who are familiar with the Facility Guidelines Institute, there are about 7 elements that are required in the safety assessment, all safety assessments for new construction and renovation projects. Only 2 of them are required. One is infection control and the other one is security. So security should get a look at during every renovation and new construction project for those states that require FGI. So I always say, security is incident driven, and I didn't coin this. It's been around for a long, long time, but it's so true. This is headlines from a local newspaper that after a mental health patient escaped from blank regional medical center's emergency room and shot himself in the head, hospital officials quickly altered visitation policies and tightened security. And it's a very frustrating kind of thing to see, because it doesn't have to be that way. But we're always looking to make changes and updates after some horrible thing happens. If you're lucky, you're the hospital across town, and you get a chance to really take a look. Gosh, what are we doing or not doing that we can look at to reduce the potential for this to happen? But I often get called after something like this has happened, and it's either the hospital across town or it's the hospital where it's happened. And I always tell them, they want to know. They want, what's the golden ticket? What's going to solve this so this doesn't happen again, or it doesn't happen at our hospital when it happened somewhere across town? I always tell them security begins in design. So more importantly, also, why is healthcare, important? And I read this it was in the New England Journal of Medicine a few years back, and it really struck a chord with me that it's underreported, ubiquitous, and it's a persistent problem that's been ignored and largely ignored if you look at across time. Some of the risk factors many of you are probably very familiar with this, but the risk factors include long wait times, unrestricted movement of the public. Of course, this is pre-COVID. Now, many of our hospitals are pretty well locked down right now, but some of those restrictions are starting to ease. Pre-COVID, many hospitals were transitioning to open visitation and allowing friends and family to visit anytime. And I think they interpreted the family centered care to mean visitors have to come in any time of the day, 24/7, And I think that may be true for one visitor, but the whole family or the whole neighborhood doesn't have to come in when someone's in the hospital. So I think possibly pre-COVID, there may be some changes on the horizon. Maybe I think I'm hearing from some of my colleagues out there that, clinical staff and others are really thinking that reducing the number of visitors is better for patient care than the open hospitals that we have currently. We're also seeing more forensic patient prisoner care and patients that have been in jails and in prisons, and then they're being housed also in the healthcare facilities on a more frequent basis. Alternatively, why is security increasingly important? Again, this is not new to most of us, that healthcare workers are at much higher risk of violence than any other occupation in the United States, short of corrections officers and police officers, and sometimes we rate right up there with those folks as well. So it's really an increasingly important problem. If we look at what are others doing, other organizations are paying some attention to healthcare safety, including the NFPA. If you look at Chapter 12 NFPA and Chapter 13, NFPA has some very extensive. They're not requirements at this point, but they're extensive chapters that are written relating to healthcare security. The Joint Commission also, if you look at the 2020 crosswalk document that's published by the Joint Commission, security is mentioned 240 times in that crosswalk. Cal OSHA just a couple of years ago adopted the comprehensive healthcare workplace violence prevention regulations as well. And OSHA is considering creating a national workplace violence standard. They've solicited input from organizations, and the IAHSS and the AHA have certainly responded to that request for some more background information. So let's talk a little bit about the security design guidelines themselves. They're a number of security. What is the IAHSS doing with security guidelines? And they're not all design related. There are operational guidelines that have recently been published relating to violence, violent patient visitor management, targeted violence, management of weapons, threat management, visitor control, violent patient visitor management, and security's role in high-risk patient watches. Each one of these are very sensitive subjects that are extremely important, and they go hand in hand with the design guidelines. So I highly encourage folks that don't already have copies of this. Wonderful. I'm getting a final warning from someone on my home message system. Sorry about that. But my point here is that the operational guidelines mesh very well with the design guidelines. The task force that put together the security design guidelines included a really top-shelf group of experts, subject matter experts from around the country, U.S. and Canada. The design guidelines have 6 primary sections, including the general guideline, which kind of sets the tone for all other guidelines. It sets the basis and relates very specifically to each subsequent guideline. The second area includes parking and the external environment. The third area, buildings and the internal environment, residential long-term care, a totally new guideline, emergency management, and a rather expanded glossary of terms. Their applicability is for all healthcare facilities. They address security early on in the design. One of my frustrations in working in this business over the years was I would often, and if this was live, I'd ask you to raise your hand if you've been asked to opine on security as the keys are being issued to your new areas. And normally in a live presentations, I'll see at least 50% of the people will, oh yeah, that's happened to me. Well, it happened to me, too many times, and that was one of the impetuses for the first edition of these design guidelines. But these guidelines support the FGI safety risk assessment, which I mentioned earlier. Some states require the safety risk assessment as required by FGI. North Carolina is one state. I think Michigan's another one that just recently made it code that you have to follow the FGI guidelines for safety risk assessments. So again, of the safety risk assessment, I think there's 7 or 8 areas Two of them are required, and that's security and infection control. So we hope the guidelines were developed to be clear, concise, reasonable, and cost-effective. And security emphasis is here. The guidelines have a security emphasis that impacts safety, emergency management, and regulatory compliance. Just briefly, the general guideline provides the background and framework for the rest of the guidelines, provides best practices to design teams. We talk specifically, and we really modified what's the definition of a security vulnerability assessment. We pretty much streamlined that to align with the NFPA's definition of security vulnerability assessment, and we indicate that it should be led by a qualified security professional. So we provided a definition for what is a qualified security professional. We'll go into that in just a little bit. I think we'll talk just briefly about some basic ZEPTED principles. We tried to build these into each guideline. We really start at the property perimeter and then move on to the building perimeter and interior perimeters, including areas segregating visitors, specifically public versus staff areas, and then highly sensitive areas. There are, if you conduct your security assessment, the vulnerability assessment, using this lens, we think that that will help moving forward with your construction project. As we look at construction, commissioning, and occupancy, the risk-appropriate security project plan should include these areas. The impact of demolition and phasing of existing site functions, need for temporary security measures, and early implementation of security measures. I know I've been involved in a number of projects, and I hate to get into too many war stories, but I got to tell one here that one of my customers had a rather large construction project that was temporarily requiring them to reroute traffic. They happened to be caring for the local prison inmates. They had a contract with the state for that, and so they had lots and lots of prison inmates. Well, one prison inmate had attempted to escape from another local hospital, and so they wouldn't treat them anymore. So this inmate was brought to this facility, and it happened to be done during the local Children's Miracle Network event. So there's hundreds of kids, there's thousands of other people on the campus, and there was a very careful plan for bringing this inmate in because he was sort of considered the Hannibal Lecter kind of person. And of course, the corrections folks that were present during the planning weren't the ones that were doing the transport, and all that was forgotten. And so they brought this inmate with, about 9 corrections officers. He's on a stretcher, and they brought him right through the middle of the Children's Miracle Network event. So early implementation of security measures, plan for those site, what's going to change on your site during the construction project, and then get those early implementation of security measures. So there are lots of other stories about during construction projects, fire, arson, contractors the disciplines not cooperating with each other and sabotaging each other's work. So the earlier you can implement those cameras, the security plan for the construction project, the better. I kind of get a little carried away when we're talking about construction and development because there's so much that happens and so much that can happen with those. And I guess being involved in this since the 80s, I've experienced probably much of what can go wrong during a construction project. So the property perimeter, let's start there. The perimeter is defined by the fencing, landscaping, or other barriers. The site security plan should depict what control points, circulation routes, and landscaping and illumination. How many of you have experienced, you have this beautiful plan that's on paper and now on CDs, and that you can have these beautiful walkthroughs. And the landscaping looks fantastic, but within 5 years, that landscaping grows over and covers up your lights, it covers up your camera views, and you're trying to fix that, and the only way to do it is either cut the trees down, and that's really difficult, or add more technology, and we'd rather plan that right in the first place and save that time and energy. Look at controlling during events and requiring heightened levels of security during special events. That's something good to plan, and look at your property perimeter or security plan during the design. This is an example of on this campus, the example I used just a minute ago, where the trees had grown up through the lights. This campus was probably 15 years old, and they'd had some very serious incidents in their parking area. So as I was doing my site assessment, I looked and I couldn't figure out what these were, but they're solar-powered lights. They almost look like zip ties around this tree, and they'd been installed about a year ago. They weren't working, and the original light fixtures were still covered up by the trees. So very a real problem, particularly after an adverse event. The attorneys from the other side are going to get this information, and you don't want to be in this kind of situation. But the use of the lighting standards, the IAHSS has a lighting standard for healthcare that's very prescriptive, and you should be mindful of that and look at that as you design the lighting for your new construction area. All of the outside areas, they're particularly in the emergency entrances and the main entrances, the lighting standards apply here, and they're very specific, and they're cited in these guidelines. And this is the specific language from the IAHSS. Hospitals and trauma centers, emergency medical and trauma facilities are by their very nature places that require a high quality of outdoor lighting, where visibility at night is critical. Also covering medical offices and clinics and helipads. Our employees and our visitors and patients are coming in at, even if you're an off-campus clinic, by the time you come in at 8 o'clock, sometimes it's still dark, and it gets dark around 5 o'clock, and sometimes we don't plan for that and design those lights to be providing reasonable levels of lighting during those late and early hours. And believe me, that's one of the first things that the plaintiff's attorneys are going to be looking at. So applying this lens and appropriate security measures to each area as you're looking at a new potential design, areas that are accessible to the public, areas restricted to public during non-visiting hours, screened public areas, staff and accompanying public areas, staff-only areas, and areas for designated staff with appropriate clearance. If you look at each of your areas and each of your newly designed projects, with this lens, it'll help you in the long term in terms of applying the CEPTED concepts. The outline of some other areas covered include inpatient facilities, emergency services, behavioral and mental health areas, pharmacies, cashier and cash collection areas, infant and pediatric facilities. And what I always tell people is, when you get your hands on the latest version, make a copy of or print off a copy from the digital version of, for example, the emergency services department. Send it to the nursing leadership over the emergency department and the medical director over the emergency department. And I'm just using this as an example, and ask them, what are these features don't they want in the next design? Whether you've got one planned or not, you're going to be renovating, you're going to be updating these areas. Get them in their hands early, because from my experience, what happens is we design all kinds of things in if we get the chance. The security director, your physical security managers, we design lots in, and then there's a phase of construction and design that comes into play, which is the value engineering phase. And it's much easier for your stuff to be value engineered out if it's just you advocating for it. But if the medical director and the nursing leadership are standing on chairs and saying, we want this stuff in, it's much more likely your security stuff is going to be in. Particularly inexperienced, maybe architects that haven't worked in healthcare much, or designers that are working at your facility that may be moved from another discipline, they may not pay security the attention that it deserves, not having had that experience. Same with behavioral health, pharmacies, every one of those, there's a very specific healthcare security design guideline for each of these areas. And I encourage you to get the version in their hands even before you have a construction project, and say, hey, next time we're looking at design and construction, we'd like you to consider these measures, and you're going to be much more successful in getting them in. Some of the other areas that are covered by the healthcare security design guidelines include PHI areas, utility, mechanical, and infrastructure areas, biological, chemical, and radiation areas, and then the completely new area called residential long-term care facilities and emergency management considerations. So let's look a bit more about the building and the internal environment. This picture is just an example of an assessment where I found recently. It's a great triage office. It has 2 doors. It has an entrance door for patients and an exit into the treatment area. But you see the area circled here. The staff member is wedged in this corner, and it would not be very difficult to reorient this room so the staff member has access to these doors, and the patient is in this corner. So staff have a potential way to escape if things start to go bad, and that would all be part of their staff training. That you designed it specifically with these things in mind. We want to design those entry areas, the interview spaces, with these kinds of concepts in mind. Some of the other areas that are covered in the building and internal environment, again, each one of these, I would encourage you to, rip out a page, give it to the leaders over those areas and say, hey, look, this is what we'd like you to consider next time, because they're considering design and updates all the time. I guarantee you, they're looking at ways of improving their areas, and I think if you get it before them and ahead of time, you're much more likely to get them designed in. This is an example of a central distribution area that I was involved in late. It was sort of a hush-hush secret thing where they purchased this building. It was a previous retail environment, and all of a sudden they're installing a central pharmacy, IT, and materials management. And it was previously a retail facility with a fence around it, a guard entrance that every truck that drove in was checked and logged in, and seals undone and seals put on after trucks enter and leave. All that went away when it became a healthcare facility until they called us in to help them develop security. Well, it was pretty late in the project. Even these roll-up doors were such that you had a pocket knife, you could cut the vinyl from these roll-up doors. So there was a lot of extensive renovation that was done at this site. And again, would have been great if we'd had these folks up front had the information about how to develop and design security-related features into these things up front. Would have been a way less expensive had we'd done it in the first place, because it was extensively renovated after that. So let's look at take a little bit deeper dive into the residential long-term care. This is all new. And we have to recognize that sometimes we've got conflicting goals here with these residential long-term care facilities, and you've got changing status in care, changing status in the mental acuity of patients. And there are sometimes conflicting goals around that, safety, privacy, dignity, and health. And, everyone wants it to be more of a residential versus institutional. So as you start leaning towards security and safety, things start looking more institutional. So it's a balancing act that the designs need to support these changes in levels of care. But this residential long-term care facilities are very similar to other healthcare facilities. You want to look at designing it from the outside in, looking at fencing or barriers designed to surround the external grounds and activity areas and roof spaces. These patients sometimes tend to wander, and again, one day they're in an apartment building that's totally like a 55-plus apartment building. They can come and go as they want. They've got cars. They've got visitors any time of day or night. And then all of a sudden, their mental acuity status starts changing, and it's that area between the time that it starts changing and the area where they're really a safety concern to themselves and others that we can have some issues with safety and security. So just kind of the general features that are covered in this guideline include video surveillance, designating a primary entry and exit from the facility where we can, vestibule designs in the main lobbies to form 2 doors between the unit and the outside, We don't want to get someone locked outside so they can't get in and stay warm while they're waiting for someone to open the door if they've forgotten their key or forgotten their card or forgotten the code. Where appropriate, use of delayed egress hardware on exit doors and equipping exit doors with hold open alarms that enunciate locally and remotely to a 24/7 location. And being mindful of securing those internal spaces or staff-only spaces, the mechanical rooms, the interstitial spaces, and really take a hard look at these designs relating to elopement and patient wandering situations. But the design should support changes in levels of care. Some of the perimeter considerations we've talked about already. This is an example of a door access, this door that would you consider this an acceptable exterior door access system for a 55-plus apartment associated with a long-term care facility? So if you have a resident that forgets the number or can't dial the number on that keypad, or maybe they have lost their glasses like me, if I lose my glasses, I'm going to be hard-pressed in some cases to identify numbers, particularly where there's not such great lighting. But if someone's status has changed and they're locked out of their building and it's in the winter and it's freezing, or it's in the summer and it's very hot, you can have a life-threatening situation. So this is what, after the incident, this is an example of what was implemented. Emergency button for help, card readers, push to open. Again, just an example of what can happen pre and post incident. Jump into the emergency department. It's been extensively updated. We're looking at an entire section was added on behavioral health areas within the emergency department. But as with the other healthcare facility areas, we look at, from the outside in, look at parking, looking at waiting areas, into the treatment areas, treatment to the interior of the hospital. That's always an issue sometimes. Oxymoron. It's sometimes an issue where once people get into your emergency department, does that give them free and easy access to the rest of the organization? And vice versa, once they're in on the other side, does that give them free and easy access to your emergency department? If you can design it right up in the beginning, you can reduce that potential greatly. So the emergency department, we also look at high-risk patient observation rooms. There's a section on that in the new guidelines. And then the locked emergency psychiatric or behavioral health sections, there's a completely new section on that. A segment that covers, what we'd like you to consider for patient rooms when you have your organization. Absolutely every organization can receive a forensic prisoner now and then, but some more than others. If you are the one with the contract with the local, federal, or state prisons, you should certainly be tuning things up for forensic patient rooms in your emergency department or other parts of the facility. And then decon rooms. What's COVID doing? These were written right as COVID was starting. I think you'll see some additional information on decon and where people are donning and doffing PPE related to hazardous materials and infectious diseases. So this emergency department scenario, I've seen this, I can't tell you how many times as I'm around the country. Bollards protecting the triage emergency entrance. I've seen, I wish I had a number. I wish I had started counting, but this happens frequently where there's no bollards and somebody either intentionally drives through your emergency department triage entrance because they want someone treated as quick as possible, or it's an accident, probably more likely, or maybe 50-50. Somebody hits the gas instead of the brake and they go through your triage entrance doors. So bollards really help. So at this point, I'm going to introduce you to a quick video that maybe highlights some potential design considerations for an inpatient ICU.
About the investigation, he joins us now. Hi, Reg.
How you doing, Amelia? Maplewood police say by law they were required to release the video because they had so many requests to see it. I must warn you, the video is hard to watch. You see defenseless nurses being violently attacked by someone they were caring for. The video from surveillance cameras inside St. John's Hospital shows a typical night. Nurses working to provide care for their patients.
A man comes into the picture. Staff begins to run.
Maplewood police say the man attacking the nurses is 68-year-old Charles Logan. His weapon of choice, a bar pulled from the side of a hospital bed where medical equipment is usually attached. Logan runs through and then back behind the nurses' station, swinging and connecting on 4 of the 8 nurses on staff.
In the hallway shot, you can see those same people are coming out the doors.
The nurses tried to get away. They even attempted to secure the doors to the ward behind them so Logan could not continue his attack.
2 of them actually fell down in the hallway, and they were repeatedly struck by the man with the pole.
It was frightening to watch, because I could put myself in their shoes.
Mary Turner is a trauma nurse at North Memorial Medical Center and a member of the Minnesota Nurses Association. She says watching the video reminds her of the dangers nurses and other healthcare professionals are forced to deal with.
Potentially on a daily basis, deal with what we're calling patient-on-nurse violence. Is an issue that's been around for a long time.
In this case, the patient made it outside before he was confronted by officers. Police say they attempted to use a taser, but it did not work. They eventually had to tackle him. Once in custody, police say Logan died. Now, 4 nurses were hurt, 1 seriously with a collapsed lung, cuts and bruises. The Minnesota Nurses Association says it has been working with the Department of Health on recommendations on how hospitals can help these healthcare professionals deal with a growing number of these type of cases.
Okay, so what are some design features that might have reduced that potential? Number one, maybe an operational function. What do they know about that guy in advance? I'm sure he had been some kind of a problem in beforehand. Could they have reduced the types of equipment in there, the pole, so forth? But design of that nursing station, is what pops out at me. If it's a general ICU, it's really difficult to design a locked nursing station, but I have seen nursing stations with higher counters and doors requiring people to have a card or to let into the nursing station. So things of that nature to look at. How easily could they secure those doors? Probably some design lessons to be learned from that incident. I'm sure many of you have seen that already. But let's jump ahead to behavioral health, mental health areas. These were extensively updated and from the perimeter out. A new concept that was introduced during one of the early days of the first or second edition of the design guidelines were elopement buffer zones. I had a client years ago where they kept having elopements and incidents where behavioral health patients that shouldn't have been able to elope were eloping. And we kept suggesting a man trap, and we had trouble because that sounded too institutional to the organization. They said, no, we don't want to look like a prison and so forth. Well, after one, we kind of took another look at it, and we said, well, it's really a buffer, isn't it? We want a buffer zone, and then we ended up calling it an elopement buffer. And that kind of stuck with it, and you'll find that term in these guidelines, and they're being installed all over. We find much less resistance to the same thing. It's a man trap. There's much less resistance if we call it an elopement buffer. People are much more amenable to putting these kinds of things in, if you call it that. And it's kind of funny, but I think we've got to do what we got to do to get some of this stuff in, and there hasn't been an elopement from that unit since these buffers were put in. But other measures, looking at very seriously at courtyards, you'll find a lot of information about the design of the exterior and in, and we all like to have courtyards where people can get outside and enjoy the outside, but there are things that we can do that should be done in these courtyards. I've seen wonderfully designed courtyards for behavioral health, but for some reason they want to put a nice table in there or something that's in there for storing things, and they put it up against the wall, and a young 18-year-old can get over the courtyard walls if we don't be very careful about some of the things that are used during the operation. And looking very closely at exit door configurations. Some clients have experienced some real resistance with delayed egress around the country, and some of it's because some of our fire departments, some of the locals aren't really on board with the latest NFPA 2012 that's been approved by the Joint Commission and CMS for those of us in the States. Sometimes the local jurisdictions won't let you do what the CMS and the Joint Commission will allow you to do, and sometimes it takes pointing out or after an incident. Sometimes then they will allow things more easily if you ask them to put it in writing why they won't allow you to do certain things. But we also want to look very closely at patient and visitor screening, security systems, video surveillance, duress alarms. There's some very specific information about those in this new guideline. A new addition is safe room considerations. How should we, some places are installing safe rooms when there's really an adverse event. Where can staff retreat to be provided a reasonable level of safety while help is on the way? Medication dispensary, there are some considerations there, high-risk observation rooms and treatment of behavioral health patients in non-behavioral health facilities. There's some additional guidance for that in those areas in the new guidelines. This is a pretty good graphic that talks a little bit about, that shows, a locked crisis intake center. I'm seeing more and more of these around the country, either inside the emergency department or standalone considerations. You want to make sure you've got a secure pathway between the ambulance area and walk-in entrances, screening of patients and visitors upon intake, to include evaluation of metal screening. Metal screening is something that I'm seeing more and more increasingly around the country for some of these areas. After, you can Google it, there have been some very serious incidents where people bring in things, or visitors bring things into patients that they either harm themselves or harm others during that process. And we already talked about the elopement buffer zone, and secure access into and out of the waiting areas is important in these situations. Another look at locked crisis intake center. Really want to take a hard look at communication capabilities for staff to include a system for rapid response. Something I've seen in several designs was there was only one way in to these facilities for responding staff. So I always encourage folks to take a look at having an alternative access point for staff members so they don't have to enter and exit through the same door that patients do. Same for clinical. The physicians and other staff members, they don't want to have to walk through the patient care milieu to get to their offices and areas where they're interviewing patients and conducting their work. So be given some real thought to alternative means of gaining access to these locations. Secure storage for patient belongings is always a concern. I've seen many places struggle with patient storage of the things that they bring in with them, from several trash bags to suitcases full of stuff, and we have to have a reasonable way to secure that. There's some thought given to that in the new design guidelines. Also, secure storage for law enforcement officer weapons. I'm still seeing some places don't provide an alternative place for officers to store their weapon when they have to go into locked behavioral health areas. There are some real horrific incidents where officers have their weapon taken from their inside locked, secure behavioral health units. So making sure that we have those things considered and implemented where appropriate in these designs is extremely important. And then space for metal screening of patients and visitors. Maybe even if you're not installing it initially for the new project, but making sure that you had space if you do want to install it in the future is important. So real quick, a patient elopement study was done. I'm not going to go into this because I've talked about these elopement buffers, but this depicts a nursing unit with the blue space is the buffer zone, and The camera coverage, you can kind of look at this later on if you're looking at putting one of these things in one of your facilities, but it shows camera coverage. The little phone thing here is your emergency in case the doors are locked and there's a staff member inside there and the doors don't open fast enough. There's a way to get help if you are locked in there with your patient and need to get out quickly. But it just shows an example of elopement buffers. So here's another potential example, and one that I was involved in early on before the first edition. And if this were a live presentation with an audience, I'd be going through, okay, raise your hand. What's wrong with this design? And I'll just tell you up front that the stairwells were placed in such a manner that this was 5 or 6 floors of clinics, and inpatient units were on the top 2 floors, and the stairwells were designed too far away from the elevators, so the access to the stairwells had to be open. And this was discovered during the design project, but too late to change the positioning of the elevators. And subsequently, hundreds of thousands of dollars were spent retrofitting this to help provide a reasonable amount of security. This is one where the keys were being issued, and the clinic managers were not happy at all with their design. It was a beautiful, fantastic looking facility, but in the all practical reality, they had to go lock in every patient room, every exam room had to be locked until we had an alternative security plan in place. That after spending hundreds of thousands of dollars renovating. So, what can you do? I would suggest get your copy now. Start talking about it with your security sensitive areas and your design staff. Talk about the importance of this, of building in some of these concepts. Include a qualified security professional in the early stages of design to assist in the security vulnerability assessment. Familiarize your team with your security design guidelines and develop. I've had some clients will develop their own design guidelines for their facility with what they think is reasonable after they've done an overall security assessment. They come up with their own design guidelines based on these, and they get agreement with their designers that, look, if you're touching a perimeter in one of my security sensitive areas, you have to come talk to the security professional. Some places, the larger folks have physical security managers, and they're intimately familiar with the design staff, and they work hand in hand. So I strongly encourage getting them copies, letting them know where are the security sensitive areas and how they should go about familiarizing those that should be familiar with these concepts. Build reasonable and appropriate security measures into each new construction or renovation project, of course, and as we've said, introduce this to the leaders in your security sensitive areas. With that, Dan? I think there's some questions folks maybe have sent in advance. And Dan, looking for you. If we have some questions, happy to take a few.
Yes. Hopefully you can hear me now, Tom. We do have some questions. I'd like to get those sent to you. And just a reminder to everyone that if you'd like to ask a question, you still have time. Please submit your questions through the Q&A window, and we'll try to get as many answered as possible. So first question for you, Tom, is what advice do you have for persons interested in getting more of these measures built into new projects? We often only are brought in at the end of a project.
Yeah, I sound like a broken record about this, but as I've said during the presentation, is you can cut and paste, you can tear out the pages of the hard copies, but get those in front of the medical director and the nursing leadership for each of your security sensitive areas, pharmacies, your clinical labs that you think may be security sensitive, and they're going to want 90%. I'll go out on a limb. I'll say they're going to want most of this stuff, and they will fight to maintain those things in your projects during that value engineering, and it happens in every project. Every project, there's a value engineering process, and you'll be much more likely to keep your security features included in your projects if you've got the way in advance, get the medical director and the clinical leadership on your side.
Great. Thanks, Tom. Great advice. Next question is, what would you consider one or two of the biggest updates that should be noted in the new guidelines?
Well, I think we really defined what a qualified security professional is. We also emphasized the security vulnerability assessment is important, and that it does provide the requirements of the Facility Guidelines Institute. I think the expanded emergency department behavioral health area, the secured area within the emergency department is a really important update. I think, and then the long-term care, those are really, really important. But I think the overall concept of building things and providing security in layers and taking a hard look at your organization in terms of, if each layer of protection is provided with the SEPTED concepts in mind, designing in the concept of, ownership for an area. Your information desks, are they placed so that they have the best view of those entering and exiting the buildings? Are there ways of funneling staff members and patients to the staffed areas? And then designing it in such a way, I think the emergency management section has some more information about, the adjacencies that we designed. How, if your infectious disease site is on the opposite side of your facility from the emergency department, how are you going to be able to transport that potentially infected patient from one site to the other in your facility? So just some examples of thinking through what are the adjacent areas that are important. And so, for example, if you put a massive retail food establishment that's going to attract customers that aren't necessarily going to the hospital inside your nighttime perimeter, and that again, another example in my career, we installed a large Starbucks inside the nighttime perimeter, and so students and others were coming into the Starbucks. It was one of the first in town, and so it was very popular, and just an example of thinking through providing that added level of security if you've moved your perimeter.
Great. And just a reminder for everyone, in the resources section, there is a direct link to the IAHSS website for those design guidelines. Next question, Tom. Does it appear that metal screening is becoming more of a standard tool being implemented in the healthcare security industry, say, over the last 3 to 5 years?
Well, I'm definitely seeing it more and more in specific areas, the inpatient behavioral health areas and the areas within the emergency department that are and it's addressed in the guideline. But I'm seeing a trend for more metal screening, in areas where behavioral health patients are being admitted during that admission process, and also some emergency departments are adding metal screening at the entrances. Sometimes, the decision has to be made: do we do it at the outer entrance so everyone in the waiting room is screened, or you do it prior to the treatment area? And there's pros and cons of either of those ways.
Okay. Excuse me. Next question. In your experience, what concentration would you look at if budget does not allow all-at-once upgrades? Outer in or more critical gaps? Wow,
that's a loaded question. I think you have to do it based on your vulnerability assessment. It's what's the biggest security issue, and what's it going to cost you to address it? But I tend to like to see the starting from the outer in and do what's reasonable, But you want to start with the areas of most critical vulnerability, and sometimes that's your emergency department, sometimes that's behavioral health, sometimes that's another area based on your vulnerability assessment. But I think the measures that you put in place are going to follow from your assessment.
Okay, great. And Tom, with the impacts of COVID and the use of perimeter screening of patients, should security professionals use this opportunity to use the guidelines to get more sustainable measures, such as visitor management systems?
I'm asked that often, and the answer is absolutely yes. I think doing what we can to get the opinions of the clinical leadership and the line staff, what do they think about added control measures? I think the places I've been, and from the employee assessments, employee opinion surveys I do relating to security, the employees are overwhelmingly supportive of controlling visitation and to not have the open visitation 24/7. So again, it's the interpretation of the family-centered care. It doesn't mean that everybody should be able to come in. It really addresses one person should be able to come in 24/7, and sometimes not even that person. It's based on the care situation. But I think most of us would be happy if we could restrict visiting to one person at night. But again, I'm speaking in broad terms. But yes, absolutely. I think really taking a hard look and evaluating and doing an employee assessment survey of leadership and the line employees. What do they think? Should we consider something different than what we had before COVID? Would somewhere in between be more reasonable moving forward? I think there's definitely an opportunity to consider that moving forward.
Okay. Another question. One of the things I sometimes am frustrated by is being asked about security after it's too late to have a major impact. Is this changing in your opinion?
ASHE did a survey, I think in 2016, and their survey, I think it showed like 60% of the facilities managers said they invited the security manager to opine on security when changes were being made. I can't honestly say I have seen a difference. I've been involved in a good number of projects in the last 24 months, and oftentimes I'm called in by the security director at the end where, gosh, we've tried to get these changes made. My administrator is allowing you to come in and help us, and it's too late. It's really too late to make a major impact and keep the cost down if you're at the end stages of design and construction. And I say that in that there are certainly some things can be done moving forward, but gosh, it makes it much more difficult and much more costly if you're involved toward the end. So I don't know. I'm answering the question. I'm a little bit elusive, but I don't know that there's been a huge change in that. About 60% do it, and I think sometimes it's just based on their perception of security, and they don't know what the qualifications are. They don't know the leader, and I think introducing these design guidelines can certainly help break that ice. Doing it early on, doing it before you've got a massive construction project in the middle of the works. Because I guarantee you, these engineering staff, the facilities planning staff, they are busy and they're trying to manage nurses and doctors and some of our other, I don't want to disparage anybody, any category, but maybe some of our other higher maintenance people in the organization. They're going to get the attention. And that's why I think it's really important to get the clinical leadership familiarized with these design guidelines. And not everyone's going to match up. They're not going to want every single one of these things to consider, but getting in front of them, then they know when there is a project, they're going to know who to call and who to talk to, the on-site manager.
Okay. Well, that's all the time we have today, everyone. I appreciate you taking the time out of your day to join us for the webinar. I want to thank our speaker, Tom Smith, for sharing all of his thoughts and experience. everything with the updates on the third edition of the IAHSS Security Design Guidelines for Healthcare Facilities. This webinar will be available on demand at the same link you used to visit it today live. It will be sent out to you via email approximately 4 hours after the conclusion of today's session. It will also be available on the MetroSense website at www.metrosense.com. Thank you again, everyone. Thank you, Tom. Have a good day. Everyone stay safe.
Thanks, Dan.